Welcome to our community awareness presentation on lung cancer. Thank you for coming. I hope we can make it a interesting and useful evening for you. We're going to focus today on screening, which is just coming to the forefront in lung cancer, and you'll hear about, and to some extent on earlier stage lung cancers, which are the sorts of things we're going to find more and more from screening, although we can also talk about more advanced lung cancer, which unfortunately is what we still are going to be seeing more, I think, than early stage. And we're also going to talk a little bit about the increasing incidence of lung cancer in non-smokers, although obviously it's still largely a disease of people who have been addicted to cigarettes. My name's Joe Shrager. I'm the head of our thoracic surgery group. And also lead what we have at Stanford these things we call clinical care programs, where we have experts from all of the different specialties who have a particular interest in one disease. And so all the people you're going to hear from are leaders in the treatment or diagnosis of lung cancer from their particular point of view. As I said, I'm a surgeon. We're going to have Leung, who's a radiologist. We're going to have Arthur Sung, who's a pulmonary physician. We're going to have Heather Wakelee, who is a medical oncologist. We're going to have Bill Liu, who's a radiation oncologist. So you'll sort of get the different points of view from each of us. I would say sometimes we doctors have a hard time remembering how much an audience does or doesn't know about something, and explaining things at a level that you'll understand. So I would say feel free, if you're not understanding what we're talking about, to speak up in the middle of the talks even, but save more substantive questions, I think, for the end when we're going to have a panel at the end. But if we're just going right over your head and you're not understanding, then bring us back down. So we're going to just start right off. The first talk is going to be from Leung. Anne is a professor of radiology and a real expert in the radiology of the chest, and particularly lung cancer.
Great, thanks very much, Joe. Good evening, ladies and gentlemen. It's a real pleasure for me to be here this evening to talk to you about lung cancer screening. Now, as many of you know, medical screening is performed to identify an important and unrecognized disease in individuals who have no signs and symptoms. And in the context of cancer, lung cancer screening is performed to identify early stage disease when the disease is more treatable, more easily treatable, and potentially curable. So in November 2010, there was a rather startling announcement that came from the National Cancer Institutes. And effectively, the NCI told the medical community that they had stopped a very large randomized trial of 50,000 patients who had been put into either a screening arm using low-dose CT versus a control arm that used annual chest radiographs. And they stopped this very large trial of 50,000 patients early because the trial had achieved its endpoint, which was to show that low-dose CT reduced mortality, deaths, from lung cancer screening. And this was really remarkable because this is the first time that a test had been shown to actually change the outcome of lung cancer and reduce deaths from this disease. And then over the ensuing 3 years, researchers have looked in greater depth at this data. And in July of this summer, there was a draft statement that was issued by the U.S. Preventive Task Force. And this is essentially an independent group of national experts on preventative medicine. And this group of experts is issuing this recommendation that low-dose screening be performed in a high-risk population. Now, many of you are sitting there and saying, well, who are these high-risk individuals? Who could potentially benefit from undergoing a low-dose CT? So using the U.S. Preventive Task Force definition, they're saying the high-risk population that could potentially benefit are current or former smokers who have a cumulative 30-pack years smoking history, 30 years minimum or more. And effectively, the way that we define a pack year is the number of packs of cigarettes smoked per day multiplied by the duration of the smoking. So if you smoke 1 pack per day for 30 years, that will achieve 30-pack years. You can smoke 2 packs for 15 years, 3 packs for 10 years, etc. Also, well recognized that cancer occurs more frequently in older individuals, so they said folks between the ages of 55 to 79, and then who have stopped smoking within the last 15 years. And it's well understood that as people stop smoking, the longer from the time of smoking, the lower the likelihood that they will develop lung cancer. Unfortunately, though, for folks who have smoked in the past, their risk is never as low as a non-smoker. And then lastly, the whole premise of screening is we're trying to identify early disease in folks who have no symptoms. By the time that folks actually develop symptoms, unfortunately, that's more serious. The likelihood of having a serious illness is higher. A screening test is really not indicated at that point, and at that point in time, we would do a diagnostic study. So you can listen to my presentation and say, well, what does that mean? So this is now recommended, but how would it affect me, or how would it affect, a family member, a friend? And what I'm doing here on this slide is really showing what is the comparative mortality reduction as compared to other procedures, other medical screening tests that are now being widely used. So here we see low-dose CT, which is being recommended now for lung cancer screening. And the number needed to screen is effectively the number of individuals who have to undergo this screening test in order to save a life. And so when we look at low-dose CT, we see that the number is 320. 320 individuals would need to be screened for 1 life to be saved. The number in brackets is the number of folks needed to be screened to reduce death from all causes, not just lung cancer, but from other things that were found on the low-dose CT, such as abnormal dilatations of your great vessels, such as the aorta, so-called aortic aneurysms, or other cancers that are identified. So when we do a thoracic CT, we will see the lungs, obviously. We will see other structures, such as parts of the upper abdomen. And so a cancer that can be incidentally found are things such as kidney cancers. All right, so need 320 to screen to reduce 1 death from lung cancer, 216 to reduce all types of deaths that could be found using a low-dose CT. The comparable numbers from mammography you can see are much higher. So we have to screen 1,300 women to reduce 1 death, and in order to reduce deaths from rectal cancer, a sigmoidoscopy has to be performed in 817 patients. And then obviously, before anybody ever undergoes any type of procedure, medical procedure, we also always have to consider there's always needs to be a discussion between the individual and the doctor as to what are the benefits versus the harms. And clearly we would not do any type of intervention unless the benefits far outweighed the harms. And when the U.S. Preventive Task Force issued that recommendation, in their judgment, they felt that low-dose CT, the benefits outweighed the harms. What are the benefits? Well, obviously the greatest benefit is early detection of lung cancer with a reduction in deaths, and that was the outcome from the National Lung Screening Trial. There are harms. And folks who embark upon this, if they decide to do that, have to recognize that there are false positives. Effectively, those are findings on a CT scan that are indeterminate by themselves, but could potentially represent lung cancer. And often these false positives are very anxiety-provoking. They require further tests, usually imaging tests, and they can be costly to society. There are incidental findings, some things that are found that are potentially could represent serious disease. Again, these can be anxiety-provoking. They may need further diagnostic tests to figure out whether they are serious or not. There is something called overdiagnosis, and that is essentially that we can identify on screening tests very indolent type cancers that if left alone would never harm an individual, cause symptoms, or death. With respect to lung cancer, this is a relatively low percentage, but you may have heard of relatively indolent cancers that are overdiagnosed, such as prostate cancers. And then there is obviously the radiation exposure. So CT scans are a diagnostic modality that is associated with radiation. And I know that there has been a lot of press recently about the harms of radiation exposure, because radiation, large doses of radiation, can in and of themselves induce cancers. Now, when you consider the benefit versus the harm, you have to recognize that low-dose CTs, they're called low dose because they are done at a dose that is lower than a regular diagnostic CT, recognizing that these studies are being performed in healthy individuals. And if you want a point of comparison, let me tell you that a low-dose CT, the dose associated with that, is the same as living in our environment anywhere in the US for 6 months. Okay, so all of us are exposed to radiation in our environment. There are radioactive materials in our environment, and the annual dose that each of us receives per year is around 3 millisieverts. A low-dose CT, one low-dose CT is about half that dose. So living 6 months is comparable to receiving one low-dose CT. And then let me talk a little bit, let me expand on this concept of false positives. So when an individual undergoes a low-dose CT scan, unfortunately, 1 in 4 low-dose scans will have a finding that could potentially be a cancer. The difficulty is that for the vast majority of individuals, and you will see I say 96%, that means 96 of 100 of these individuals who have a study that is called positive eventually prove to have benign findings. That means they don't have cancer. Now, in order to differentiate between these benign, non-cancerous findings in cancer, that requires follow-up. And the follow-up for folks who are being screened for lung cancer is usually further imaging, okay, further diagnostic tests such as imaging. In some situations, particularly when there's a very high level of concern that the finding actually represents a cancer, obviously physicians and patients want to be more aggressive. And in that instance, sometimes invasive procedures will be performed. And Dr. Sung, who's going to talk right after me, is going to talk about the diagnosis of findings on CT scans. And then finally, I just want to finish up by talking about the current status of lung cancer screening at Stanford. This is, for us, a physician-referred examination. So right now we are not accepting self-referrals by patients because we think it's important that patients have an opportunity to talk to their physicians to ensure that this is the right test for them, particularly with the false positives. It's not currently covered by insurance. We are hopeful, because of the Affordable Care Act, that these services will be covered in the future, because the U.S. Preventive Task Force basically provides guidelines to the government as to what should be medically covered by insurance. And then for any individuals who are either thinking about doing this themselves or recommending it to friends or relatives, I provide 2 educational resources. One is the U.S. Preventive Services Task Force website, where they go into the National Lung Screening Trial and the evidence that they reviewed in order to come up with this recommendation. And then lastly, there is on the YouTube this series, or 3 parts of a video, which essentially is entitled CT Scan at Stanford. And it documents the journey of one of the Stanford writers who herself decided, because she was a former smoker, that she wanted to undergo lung cancer screening. And so I think this is, in particular, a very educational video. Thank you very much.
Must have a clock in her head, 10 minutes exactly. Arthur Sung is comfortable in this bad weather because he joined us from New York City about, 3 months ago, Arthur? Arthur is very expert in a sort of a newish field called interventional pulmonology, where pulmonologists use the bronchoscope and some other sort of quasi-surgical maneuvers to help in the management of lung cancer. So, Arthur.
Thank you, Dr. Shrager, and it's a pleasure to be here today. I think as a pulmonologist or a lung doctor, we have to first and foremost recognize as now the clinician who is sort of the one who's talking with you, having a conversation with you. When your doctor said, hey, a report that we sent for a screening test, or actually, even now in my practice, most of the time, you have a cough, a cold, had a chest x-ray, and suddenly you're told that you have a spot. We have to recognize that nothing can be more anxiety-provoking than that sentence. So what our role is, it's really to have both the reassuring part, as Dr. Leung has stated, that most of the nodules that are found, the overwhelming majority of them, are going to turn out to be benign. And what we will have to do is to have a strategy to basically have a plan going through time to prove that that is actually the case. Or on the other hand, if there are risks and features of the nodule that are very worrisome, it's also a responsibility to guide you to the myriads of mazes of complexity of the medical system. But within our Stanford system, we have a really expert panel that we can assist in our progression of management of this disease. So I'm not going to belabor and embellish the point, but CAT scan, this is a spot that was found by a chest x-ray and then subsequently a CAT scan. So this is a spot, a nodule, a shadow, whatever that is really understandable to you, that's what it is. This can be a whole myriad of possibilities. Certainly cancer, although it's one of the possibility, but it still could be a minority of the possibilities. So as a pulmonologist, so as a lung doctor, I'm not going to quiz you on any of this. Just know that there's a whole list of possibility of what a spot can represent. Other than neoplastic on this column that could be due to cancer, you have to understand that there are a lot of reasons why either there's an infection or that's some fungal infection or anything such as when you're younger, you have connective tissue disease like lupus, for example, or something that's been really benign that you've had all your life that never had known that you have a spot until you get that one chest x-ray that uncovered that there's a spot there. So just realize that that's not, just so you were told that you have a spot does not mean that you have lung cancer. And this is our job as an expert panel to sort this out. So this is an example of a completely benign spot that looks quite scary looking. This has actually got a lot of fat in it. And this is something that I bet you, if you look back many years ago, it's been there for ages and ages and ages. So one of the first key questions that we try to delve into is whether you've had a chest x-ray sometime in Central Valley 10 years ago. If it was there before and it's there now, hasn't grown, case closed. So this is another example of a infection that was old and basically has some calcium. And this is something that's a little looking different, that we may act a little differently. And this is a type of very slow growing tumor that Dr. Shrager would give you a curative therapy. Well, certainly, now that we said that CAT scan is a very advantageous modality to detect the spot, well, it is possible for us to do a procedure in the CAT scan. However, this is both impractical and also has a lot of risk involved by doing a procedure within the CAT scan, although it is possible to be done. So you can see, for example, this is a physician, either a lung surgeon or pulmonologist, using a very flexible camera, and this is a patient, of course not showing any faces, to insert the camera into the mouth that's numbed up and the patient is sedated, and we can use the camera or the CAT scan to validate that you are actually within a spot within the lung. Now that's a nice idea, but to facilitate, to use a CAT scanner while it is needed for Dr. Leung to really do her work and we taking up all the time, that is actually not practical. So what are the other things that we could do to help identify a nodule by a sampling of the nodule, i.e. a biopsy, that can also be feasible? Well, this is actually the inventor of a bronchoscope. In the 1966, it was invented. is a very, very bulky machine. And nowadays, it's much more miniaturized. So I'm not going to talk about everything that we do. I'm only going to talk about two things. One is using, quote unquote, a GPS system to guide us from the windpipe to a particular spot in the lung. And that's what we call at Stanford the navigational bronchoscopy system. And then another hugely important modality that both us and the thoracic surgeons like Dr. Shrager utilizes in the operating room or in the procedure room is to both look at the lesion itself by a real-time ultrasound, which I show you by pictures, and also if someone were to have been diagnosed with lung cancer, to see the extent of spread. So these are pictures now. So first, I do not want to, because we don't have an interventional radiologist here, just know that they can use a CAT scanner and using a needle and basically use the CT scan to mark the spot precisely and use the needle from the outside, numbed up with the skin, and then same-day outpatient procedure that they can actually get a very good sample precisely for the patient who has a spot that needs evaluation. And this is an example of a patient that's lying on the side and having a needle through. Now, from the bronchoscopy standpoint, now we're in the 2013 now. What we now have is that the radiology department under Dr. Leung's guidance are now giving us a very beautiful representation of the CAT scan. We can actually use the normal CAT scan that you see or we see in the clinic and generate it into a virtual environment into the lung. And what it does really is that it gives us a lot of information in terms of the branches of the tree. That is what the lung looks like, and tell us by the purple pathway to guide us to go, hey, go to the right, right upper, go to the back, go to the front, go to 6 o'clock, eventually get to that spot. Now, is this a home run? No, but I think that it is a very good assistive device in terms of getting us to the spot much more precisely. So this is just one example of that guidance system that lets us to go to the right side of the lung, correlating with the CAT scan that's generated by the CT scan. And this is just different planes over the course of time. And this is at the end where the camera or the scope reaches a nodule that we can now use biopsy tools to get a sample that's small and allowing the pathologist to hopefully get a very good diagnostic sample. So these are just some other representations of a procedure itself. And we use a lot of catheters that helps us guide us into the right spot. So this is one representation cut of what it looks like. This is a cartoon of the patient's actual lung. And we go follow that path. So quickly, another thing that we use to help us now, instead of using a CAT scan, is actually using a tiny little probe that we feed into the lung tree itself. And the probe turns itself 360 with an ultrasound and generate an image for us to tell us that there's a camera, this is a probe that has a balloon, and it can give us a real-time image of what a lesion looks like. And tells us in the real time, hey, you are at the spot, it is safe to go ahead and biopsy because it is not without any blood vessel around it, and you're right there. So this system, which is available now, is going to allow us to be able to sample much more precisely and safely. So this is a cartoon representation of how this probe can go into a lesion itself. Lastly, the thoracic surgeons such as Dr. Shrager and us is also, and they're going to talk more about this, but just to leave these images, in terms of lymph nodes, just because they are lesion itself, we sometimes are interested what the lymph nodes around the windpipe also represent. Does it show infection? Does it show a benign disease called sarcoidosis? Or does it show cancer? So this modality of using a camera inside the trachea, using an ultrasound can tell us precisely that we are in the sample safely without blood vessel involvement that may risk a bleeding and get a good sample there too. So this is an example of a needle within the lymph node. And we get the samples and the pathologist can look at them under the microscope and give us an answer of benign or malignancy or something that needs surgical evaluation. So we put in different various forms of solution to test. And just go back to the beginning, now that we talked through all this modality. Again, as a final thing to say is that we cannot forget we are really facing an individual in front of us. Everyone has a different story. So other than looking at the nodule, the patient's age, how many years they smoke, the size of the nodule, and everything else, we actually incorporate everything together in terms of synthesizing a probability in our mind to help us guide the counseling the patient. Hey, what's the best thing to do? Do you do another CAT scan down the road, which is actually the majority of what happened with the patients in the trial that Dr. Leung talked about. So anyways, in summary, I give you a little bit of a taste of what we do. We try to get more minimally invasive technology to complement what the radiologist does to look at the lesion and what the surgeons do in terms of sampling it in a definitive way. So we're sort of somewhere in between. And then we really need to combine the clinical assessment and radiographic features, understanding the anxiety that's involved. And luckily, I do collaborate with fantastic colleagues. So thank you for your attention.
The next talk is from Heather Wakelee. We're going to move more into treatment once you have an answer, if you do have lung cancer. And Heather is an associate professor of medical oncology, I guess associate professor of medicine, who's an expert in medical oncology, and she treats maybe more lung cancer patients than anyone around. So Heather, I think, had her computer stolen over the weekend, so we'll be speaking with no slides.
Capable of speaking without slides, but we're good. Yeah, so I'm not going to have any slides, so just sort of speaking a bit more without the lovely slides you've already seen before. So you've heard a lot already this evening about how do we look for lung cancer, and if we're suspicious about it, how do we figure out if that really is what it is or not, just to give you a sense of that. But I think probably most of you who are here today are also thinking about, okay, well, that's all good, but we're here because somebody we know has lung cancer, or maybe some of you have lung cancer, and really interested in the treatments. And we've seen tremendous advances in what we can do to find lung cancer early and hopefully be able to do more, cure more people. We've had tremendous advances in what we're able to do to diagnose it in a quick way. But we've had even more tremendous advances recently in what we're able to do to treat the disease for a lot of patients. And so as a medical oncologist, many of the patients I see are diagnosed when the disease has already spread. When I still have to tell them, we have a lot of things we're going to be able to do, but I don't yet know a treatment that's going to be able to cure, which means I get to see many patients regularly and get to know them very well, which is a wonderful thing. But it also means that they probably have to see more of me than they want to. So we're working hard to get to treatments where we'll be able to do more to give people more time, where they don't have to come in and see their medical oncologist every 3 weeks or more frequently. And in order to do that, the advances that have been made are in better understanding of the disease. So when I first started treating patients with lung cancer, I was always asked by the pathologist, okay, well, we know it's small cell. I'm like, okay, that means something. Or it's non-small cell lung cancer. And they would then go in to describe, well, it's adenocarcinoma versus squamous. But for me as a medical oncologist, way back when, those distinctions didn't actually matter, because I knew that I was going to be able to offer chemotherapy, and that was all I was going to be able to offer. And sometimes it would work, and sometimes it wouldn't work. But that's what we had. But then things have started to change. And so now it actually really matters if it's adenocarcinoma versus squamous cell versus something else, because some of the chemotherapy drugs work better for different types of histologies, and some of them are more toxic for different types, so I have to know that. And that was the first step. But then we decided that wasn't enough either. Now we need to know more about the genes of the cancer. So what we figured out about lung cancers, and other cancers too, but especially in lung cancer, is that usually something has happened to the DNA of that cell that started the cancer. Something changed in the DNA of that cell so that it didn't behave the way the rest of the body behaved. It was different, and it was that difference that led to the cancer, that led that cell to continue to grow when it should have been attacked and killed by the body's immune system, that something was wrong with it. And as we've started to understand that, we've been able to discover better treatments that we can really use to make a dramatic impact for patients who are living with lung cancer. We're not at the point where we can figure that out for everybody yet, but in the last 10 years, we've gone from never being able to do that to being able to do that for over half of patients now. And that number keeps expanding as we learn more of these. So the first example of that is something called the epidermal growth factor receptor, or EGFR. And what was discovered was there were medications, that actually happened to be pill drugs, where some patients who got these pill drugs who had lung cancer, their cancer just went away very fast. And so people were able to figure out, well, there's something about that gene, that EGFR gene, that's different in those tumors. So it's not in the person themselves, it's just in the cancer. And that's one thing I want to try to explain to you, because people wonder, well, if I get lung cancer, can I spread it to my kids or my grandkids? And the answer is no, not in a way that we know right now. Not that we've been able to figure out, because these gene changes aren't in the rest of the person, they're just in the cancer, which means that they're good things to go after, because we can go after them and go after just the cancer without actually hurting the rest of the person, which is obviously crucial. So with EGFR, what was discovered was if you can find that gene change in EGFR in a tumor, then you know that there's these drugs that work particularly well in that setting. And those patients who have that kind of tumor can avoid chemotherapy. Not forever, but for a while, and have a good response. And with time, we've figured out more and more drugs that work particularly well in that setting. But that was just the start, because that's only about 10% of people with lung cancer. It's more common in adeno than others, and so there's more to do, but it was a start. Then people figured out about something called ALK, or ALK. And that's also maybe 5 to 10% of all lung cancers, but at least it's a piece. And so, and with that, we also have new pill drugs that work particularly well. They're not a cure yet, but they provide a dramatic impact. And when we think about lung cancer now, we can think about it being a kind of a big pie of all patients with lung cancer and all those tumors. And we're now able to kind of break that up into different pieces and no longer think of it as all lung cancer, but sort of it's lung cancers. They're all kind of different diseases. Some parts are the same, but some aspects of it are different. And when we can figure that out, we can provide very different treatments. And so in one aspect of the research is trying to figure out those molecular changes, those gene changes in the tumor, where we can then tailor the treatment better. Now, the thing that's been going on in the last couple years, even away from that, is better understanding of the immune system and better ways to get the immune system to better attack lung cancer. And so that's also been dramatic changes, and that's much more recent, just in the last couple years. I remember when I was in college, which I won't tell you how long ago that was, but it was a little while. One of the things that got me interested in becoming an oncologist was this idea that we should be able to get the immune system to better understand cancer and attack cancer and help us fight the disease from within better. But it took a long time before we actually made much progress there. There were, with melanoma and some other diseases, little steps. But with lung cancer, we weren't making a lot of progress, unfortunately. But in the last couple years, we now have drugs that focus not on a vaccine strategy, but on actually changing the immune system, sort of revving it up a little bit, but in a way that focuses on the cancer and not on the rest of the body so much. So these drugs are called PD-1 or PD-L1 or checkpoint. Some of you who are reading the newspapers have seen these. And there are many of these drugs now in development. And we keep getting reports that there are very good responses. This, again, it's not everybody. So we're still trying to figure out how to make sure we can help all people with lung cancer and not just certain groups. But if we can figure out all the different groups, then we eventually get to a point where we can help everybody a lot. So we're making progress. It's still a little slower than we'd like it to be, but it's definitely picking up. And so now when a patient comes to see me who's been newly diagnosed, we talk about not just that it's lung cancer, we obviously talk about that, but then we try to figure out if we can figure out a specific subset of lung cancer that that person has and how we can change the treatment based on that. And so when people come to see me, we're able to talk about, hopefully having time that stretches out beyond what I can even have been able to talk about with people before years and years, because I see how fast these new treatments are coming along. And so that's where we are. Now, my assigned topic today was to talk about lung cancer and never smokers, and not just sort of the what are we doing in treatment of lung cancer in general, but I think it's important to talk about where we are with the medical oncology treatment, because there's been so much progress and a lot of hope. One of the things that had slowed down the progress of treatment of lung cancer in the past was the stigma that's associated with lung cancer, and that comes from the smoking aspect of it. And that's really been unfortunate, because obviously, no one deserves to get lung cancer ever. And no one deserves to get any cancer ever. But because some of the people who get lung cancer have a history of smoking, it's been easy for the government, for the community at large, to sort of try to place the blame on the cancer on the person who got it, as opposed to saying, this is a tragedy, what can I do to help? And so I always talk to my patients about that issue, because most of them still find that when they announce that they have a lung cancer diagnosis to their friends and family, even though people don't mean to, they still get that question about, did you smoke? Kind of representing the fact that that stigma is still there. And it's because of that stigma that a lot of the funding to do the research to move forward has been limited. We're slowly moving out of that, which is wonderful, because it really shouldn't be about anything about what happened. We need to do a lot to try to control smoking. I mean, it's something that can cause health issues for many people. But most of the people who started smoking long before we knew about those health issues, and it's a very addictive product, so it's not something that's easy to quit. So we certainly need to still focus on that. But we also need to move beyond that and focus on lung cancer as a whole, realizing that it's something that can happen to everybody. And so being here in Northern California, many of my patients have no history of smoking, have no exposures that we can come up with, who get this disease. They still have to face those same questions and still have to face the stigma of the disease. But we're all hoping to work together as a lung cancer community, regardless of smoking history, to really figure out how we can pool resources and fight together to get this disease to be something of the past. We've heard about how we can screen for it, and the screening is still focused on people with a smoking history. We haven't yet figured out how to do the screening for people who don't have a smoking history. We haven't yet figured out are there any potential genetic links that can lead to that? There's been some work, but we're still a long way off from understanding that. But again, the science is moving forward, and as more and more people are willing to talk about it, to say, I have lung cancer, I know someone who has lung cancer, we need to do more, we're moving more and more forward. And so I'm really touched to see so many people here tonight to learn more about lung cancer, to speak about lung cancer, to maybe meet other people living with the disease, to ask questions. And so I want to thank you all for being here. And we'll be, yes, sir. So the PD-1 and PD-L1 drugs are still in clinical trials, but there are many clinical trials that are open. And some of them are actually in what we call the phase 3 part of the development, which is sort of the step before things actually go to the market. When we're developing new drugs, we go through multiple phases of development. The first is the phase 1, and that's where we hope the drug will work, but we don't know what the dose should be, we don't know what the side effects are going to be, we don't know if it's going to work at all. When things show promise, then they go into phase 2. And in phase 2, that's where we start looking to see, are we really seeing an effect? And if things look good there, then they go into phase 3, where they're compared to the standard treatments that already exist to see if it's actually better than what already exists. And so some of these drugs are already in the phase 3. Some are still in phase 1. But there are about 5 or 6 of these drugs that are being developed, and we don't know which one's going to be the best. Maybe it's that you can go with one and then to the next and then to the next. Those are still questions being developed. But we have trials open, UCSF has trials open, UC Davis has trials open, there, and many of the community centers do as well. And it's because we all recognize that these are very, very hopeful. And soon, I expect within the next year or two, there'll be things that people can just prescribe, but we're not quite there yet. Yeah. Yes, ma'am. That's a great question, and I realized as I was speaking today, I've really been talking about patients with advanced disease, with metastatic disease. And your question is getting at, well, what about patients who have early stage disease? What about patients who are hopefully cured? They've had surgery for stage 1 or 2, or even stage 3, or they've had combined chemotherapy and radiation for stage 3, and hopefully they're cured, but we know that there's still a chance of the cancer coming back, and what can we do to reduce those chances? And so far with the work that's been done, the only thing that we know can make a difference after surgery is chemotherapy, but it doesn't make enough of a difference. It does something and we encourage it, but there's more to be done. So the question then about these molecular testing, and well, what does that mean for someone where they don't have cancer anymore, it's been removed, what can we do to reduce the chance of it coming back? We don't know. We don't know if giving the targeted drugs in that setting or giving the immune-targeted drugs in that setting helps improve cure rates. So there are trials ongoing trying to answer those questions, but we don't have the answers yet. And so when I have a patient who's had surgery, they often will get the testing done, but then that's information that we keep in our back pocket and hope we never need to use. Or we talk about clinical trials, but it's not something that we know can help to cure right now. And so if someone's had a surgery, they have no evidence of cancer, but we know that their cancer that was removed had an EGFR mutation, I'm not recommending that they get that kind of treatment except in the setting of a study. And I think Dr. Shrager's standing up to pull me off, so we'll do more questions later. Yeah, and we do have trials open.
For several of the targeted drugs to add to potentially curative surgery, hopefully curative surgery.
Right,
But we don't do that outside of trials.
right.
It's sort of still experimental. We just add it.
Right. And also with patients with early stage disease, stage 3, where we're going to be doing chemotherapy and radiation, we are now testing before we start the chemo and radiation, and in the setting of clinical trials, building those treatments, those targeted treatments in, but still under investigation.
Let's say, can we save them until we have the panel? We'll answer. We'll stay as long as we need to answer all the questions.
I think Dr. Shrager wants his chance to talk too, so I'll stay around later too.
No, I'm under strict orders. So I'm going to go back to talking a little bit about smaller lung nodules that we hope and think we're going to see more and more of with screening as screening becomes accepted, paid for, et cetera. And also we see more and more just because people getting CAT scans for other reasons will often have a little lung nodule that turns up and does turn out to be a lung cancer. So this is at a way earlier stage than most of the patients Dr. Wakelee is talking about. So this is the kind of thing that we hope not to see, and we used to see a lot more of, and I hope we're going to see less of, but a really big tumor. Sometimes we can do very well with a tumor like this, especially if they have a targeted, a molecular target, like Dr. Wakelee was talking about. But now what I see, anyway, as a surgeon, is more and more things like this little thing here, or this little tiny thing over here. These are the kinds of things we often see on screening. I think I just lost my pointer. See my hand moving, but I see nothing there. Or this one down here. And you can see they look a little different, but all of those did turn out to be some form of very early lung cancer. So you've heard about diagnosis from Dr. Sung. Not all of these necessarily need to have a diagnosis, but rather can sometimes go directly to surgical incision if we think that they look like they're probably going to be a lung cancer. The reason that we do that is because we now don't have to make a big incision in everyone's chest to do lung surgery. We can do a very large percentage of what we do, especially for these small tumors, with very small incisions and what you call in the belly laparoscopy, we call in the chest thoracoscopy, or VATS. You would have heard the term VATS. Sometimes, if it does turn out to be a cancer, we need to do more than just remove that nodule to prove what it is. But often that can all be done at the same sitting. So here, for example, again, I can't point, but the dotted line there is sort of an old incision that we would make, and we have to cut the latissimus muscle, the lat, and spread the ribs. But now we can, most of the time, make these 3 small incisions, and we go with a video camera and then long instruments through the other incisions. And so it ends up looking like something like this, where the camera goes through that lower hole, and then instruments and sometimes a finger through the other incisions there. And obviously, it hurts less, is really what it boils down to. It hurts a lot less. And we're looking up on a TV screen, the surgeons, one screen on each side, and then working down here. This is what it looks like. This is actually a picture of someone's lung with a little nodule on it, okay, which we didn't know at this point was going to be a cancer or not. And we can put a finger, we can grab the lung with these long instruments and put a finger in and identify the nodule. And then we take these stapling devices that have been designed to basically cut through the lung and secure it. And then we take the nodule out in a little bag, and we then send it to the pathologist, and within 20 minutes or so, I wish it were shorter than that, we know what it is, and then we decide, was that enough, just wedging it out, or do we need to do something a little more extensive? So this is a picture of the types of operations we do, different sort of amounts of lung we sometimes have to take out for lung cancer. And the sort of standard is to take out a lobe of the lung. And you can see in the circled area, on the left side, there are 2 lobes. And here there's a cancer in the upper lobe, and sort of traditionally the operation for that would be to take out the entire left upper lobe. And we can do that with a video camera as well. I won't go through the details, but this is showing this is actually from an operation, showing each of the parts of the lung being dissected out and then being divided with these stapling instruments. And then the whole lobe can be removed in this big bag, believe it or not, through an incision about this big. And nationwide, about 20% of operations on the lung are being done that way through a video camera. I mean the more complicated operations where you have to dissect out blood vessels and that sort of thing. Here at Stanford, it's about 70%. But obviously, we wouldn't even consider doing it unless the cure rate was equivalent to doing it with the big open incision. And it's been very well established now that for a stage 1 lung cancer, where it hasn't spread to the lymph nodes, having it done through the video camera and the small incisions by a qualified surgeon is just as good as having that big incision. We have some debate still in our field about whether if there are lymph nodes involved, you should do it that way or not. And so we talk about each case. And you have reduced pain, and you can get back to your activities sooner, less complications. And for patients who do need chemotherapy, they're able to get the chemotherapy sooner, and it's been proven that more patients get all the chemotherapy that they need. Whereas if you've had a thoracotomy, sometimes people are just a little too weakened to get through all of the chemotherapy that's been recommended. But there are two big problems with VATS lobectomy. One is your surgeon has to be a very good surgeon. The fact is there aren't that many people who are experienced enough to do it well. I think that you have to have done 300 open lobectomies, and I would not recommend, if you ever are going to have a family member or somebody who's going to have a VATS lobectomy, make sure the surgeon can look you in the eye and tell you that he's done 40, 50, 60, hopefully 100, because it takes experience and there are occasional problems. You can imagine if you get into a big artery that's coming out of the heart and you don't have an open incision to fix that, it can be very, very traumatic. And the second thing is that we're still removing an entire lobe of the lung when we do a VATS lobectomy. So the next sort of evolution in surgery is to try to take out less, especially for these little nodules that we see now more and more because of CAT scans. Can we take out less of the lung than the whole lobe and still have the same chance of curing someone? So there's a lot of research going on and a move towards sort of taking out less. That's particularly relevant for these things we call ground glass opacities. Ground glass is sort of like at the swimming pool when you were a kid, the glass you can sort of halfway see through. We see these lung nodules, and I'll show you them again, that sometimes are ground glass in appearance. Those often are in non-smokers, and they basically will not spread. And so we are starting to be pretty sure that we can just do a local excision of little tumors like that and not have to take out the whole lobe, although it's still a little bit controversial. So what are these lesser sublobar resections, less than a lobe? We can do just a wedge resection where it's just a nodule and a little bit of normal lung around it, or we can do a segmentectomy. That's taking out a segment of the lung, which is bigger than a wedge and smaller than a lobe. And I'll tell you a little bit how we make that decision. And I want to make the point, I can speak the point, but I can't make the point. A solid tumor like this one over here, see what solid, dark white, those, even when they're small, have about a 15 or 20% incidence of spreading to the lymph nodes. So if it's in the lymph nodes, we need to take out the lobe so we can get all tumor cells that are in transit towards the lymph nodes from the tumor and all the lymph nodes. For something like this is what I would call a half ground glass nodule. This part's ground glass, and this is sort of getting solid-ish. That type of tumor, we would probably lean more towards taking less of the lung, because it's very unlikely, it's been shown now, if it's less than 50% solid, it's very unlikely to spread to the lymph nodes, maybe 1%. I'll just skip that slide. Someone timing me? So the question is sublobar resection appropriate for ground glass opacities? And without showing you the data other than what you can look at there, the answer is yes. I'm increasingly convinced, and that's what we're doing now. Usually a segmentectomy, but sometimes just a wedge resection. I raised that question, is just a wedge resection enough, or should we do a segmentectomy that allows us to get at that sort of first lymph node that a tumor might spread to that's embedded in the middle of a lobe? And probably the data is not what we call randomized data, which is in science we think is the best data to prove an answer to some question. But you can see the numbers. The recurrence rate is something like 71%, I should say. The survival or cure rate is about 71% if you do a segmentectomy. This is for solid tumors, okay, not ground glass tumors, and about 48% if you do a wedge resection. So for solid tumors, we're very hesitant. But for ground glass tumors, the data is completely different. And as I showed you, suggests that we can often just do a wedge resection or a segmentectomy. So what we're doing these days for these small tumors that we often pick up in screening is if it's an appropriately located, less than 2 centimeter, pure ground glass nodule, we'll often just wedge it out, okay? If it's got any solid within it at all, which usually the solid part of these tumors represents the invasive part, the part that has a chance to spread to the lymph nodes. And if we see any solid in it, then, it's in a good location to do a segmentectomy, again, not a full lobectomy, but a segmentectomy, then we'll basically set out on a course to do a segmentectomy. We'll check the lymph nodes during the operation to see if they have cancer. Our pathologists look at them right away. And if there's no cancer in the lymph nodes and we get a good margin doing a segmentectomy, then that's all we'll do. But at any point, we might switch to a lobectomy. So that's the conversation that I have with patients who have these nodules. We'll go into the operation intending to do this, but somewhere along the way, we may find a reason that we have to do a lobectomy. And it's only for bigger tumors that we sometimes take out someone's whole lung. So we see lots of small nodules now, many more. And I should mention, we see, because of our large Asian population in this area, there seems to be some sort of genetic predisposition to EGFR mutation tumors in Asian women. So we see a lot of that. I really think that our institution is the world's expert in that outside of some of the Asian countries. Many of them are non-solid, that is, they're ground glass opacities or part solid, and many are in non-smokers. These are smaller, less aggressive tumors, and they allow less aggressive surgery. And VATS techniques, the thoracoscopic technique, can be used for most of those operations, and the cure rates are quite high. So I thank you for your attention. Bill Liu is an assistant professor of radiation oncology who is going to tell you about another way of treating lung cancers. We use radiation for both big tumors that are not candidates for surgery and occasionally for small tumors that might be candidates for surgery as well. I've done about 2,500 open lobectomies for lung cancer and about 600 VATS lobectomies. And then that's including segmentectomies also, which are sort of the hard ones. Just about any surgeon can do a VATS wedge. That's just sort of pick it up and take a stapler. But when you have to dissect out the vessels is when it gets into some expertise. Yes? So typically, so I can't speak obviously directly to your experience with your mother. We can see diffuse ground glass opacities. We can see focal ground glass opacities. They can represent benign things, okay? I'm talking about focal ground glass opacities that we've proven or have a high suspicion of are early stage adenocarcinoma. So they typically represent adenocarcinomas, and they're adenocarcinomas before they've become invasive, okay? When they're basically still what we call in situ adenocarcinoma. In situ means it hasn't invaded into the tissue of the lung, giving it a chance to spread. So there are lots of things that ground glass opacities can mean, but in a certain circumstance, a clinical scenario, we can usually have a good idea whether they might represent small in situ adenocarcinomas. Okay, Bill?
All right, thank you. So many thanks to my colleagues for having laid a lot of groundwork for the discussion tonight. We're going to talk a little bit now about the role of radiation therapy. And radiation therapy is used to treat lung cancer in many different ways, most often historically for somewhat more advanced cancers than what you've been hearing about tonight. But our focus tonight is primarily on these earlier stage lung cancers that hopefully we'll be picking up more and more of through these early detection and screening types of strategies. And so I'll talk about a relatively new form of radiation therapy. At Stanford, we've been doing this since about year 2000, which we're one of the first centers in the United States to have started doing this, but now it's actually become much more widespread. So we refer to this as SABR. I'll explain what that means in just a little bit, but it's a very high precision radiation therapy for early stage lung cancer. So as you've heard, the treatment of early stage lung cancer, historically surgery has been the gold standard, and we can have very high cure rates, sometimes 70% or more, if the patient can receive the optimal therapy. And you've heard about the differences between lobectomy and sublobar resections. But the goal of surgery is to cure, and it's a very successful strategy. The issue, however, is that many patients are not able to tolerate surgery. Often 20% or more of patients may have health issues, heart disease, lung disease, other things that prevent them from safely having surgery. And so we need to have good alternative treatments for patients like this. Particularly with the aging of the population, many patients are diagnosed at older ages, and they may not be able to tolerate as invasive a therapy. So the standard alternative in the past has been conventional radiation therapy, small doses given every day for a period of several weeks. It was an effective therapy, but certainly not as successful as we would like, not really comparable to surgery. And so what we're talking about now is a new alternative to that. So really what we're talking about is, in terms of early stage lung cancer, is three key groups of patients. Those who have sort of standard risk for going through surgery and can have the usual standard treatment. And then those patients who may be able to tolerate surgery to some degree, but they have high risks. And then there are those who are outright unable to tolerate surgery, and we refer to that as medically inoperable. So what is SABR? It's a short name for stereotactic ablative radiotherapy, and it's highly focused radiation. We achieve this by using many different radiation beams, all focused on a small tumor. It's very dose intensive. An entire course of radiation is compressed into a single treatment or a few treatments, as opposed to split up over several weeks. And so it's a very, what we call, biologically effective dose of radiation. And it requires being very accurate and precise using technologies that we haven't had in the past. And much of that is what we refer to as image-guided therapy. So we use better images, such as the type that Dr. Leung talked about before, but to direct our radiation treatment. Other names you may hear about are SBRT or radiosurgery. These are sort of synonyms for the same concept. So this picture here just illustrates the difference between what we used to do in the past with cruder technologies. We would have a radiation beam hitting this tumor, one coming from the front, one coming from the back, and these lines here represent the radiation dose, and you can see it's spread out throughout the entire path of the radiation here, and the highest doses may not even be right where the tumor is. And so all of this normal organs here get the same radiation dose as that tumor. Whereas in this scenario here, you have beams coming in from many different directions, all focused on this tumor, and the highest doses are right on the tumor, not spread out into the normal organs, or a much lower dose spreading out. And that allows us to give what we call ablative doses of radiation. If you try to give an ablative dose here, you destroy way too much normal tissue. It's not safe. So the main advance is the ability to give this high precision focused radiation. So it's more, SABR allows us to give more intensive, effective radiation doses with less damage to the surrounding organs, and it's also faster and more convenient. So how do we do this? So there's two phases. One is the planning phase. We have to see our target. And so there's a planning session that we start with, and I'll just describe that briefly. And imaging, scans are a big part of that. And then there's the part where we have to hit the target. And so we have to understand that we're treating moving targets. These are lung tumors. Patients breathe, the tumors move. And we also take images at the time of treatment, make sure that we're always on target, and we need strategies to manage that motion. So this is a scanner. It's a PET CT scanner that we might use to help the planning phase of the radiation, where we position the patient and also take images throughout the breathing cycle. So we can actually make a movie that looks like this. So here's a tumor in the right lung, and you can see as this person is breathing, the tumor is moving up and down quite a bit. And so in some cases, the motion is large, in other cases, it's small, but we need to manage that. In addition, we can apply the technology of a PET scan as well. And so now we can see which portion of the tumor is very active. We can see there's actually a portion underneath there that we saw earlier that's not active and actually represents a little bit of collapsed lung rather than the actual tumor. So how do we deal with this motion? Well, one way is just to make the radiation beam big. If we make it big, we know we're not missing, but that's not the best way to do it because then we give radiation to areas of the body that don't necessarily need it. Another way to do it is to use a smaller radiation beam, and we turn the beam on only at a certain portion of the breathing cycle, so we can synchronize it with the motion of the tumor and give basically better focusing of the radiation. And another strategy is to actually follow the tumor around with the radiation beam. This is a tracking strategy. All of these are available for us to use in the clinic currently. This is what one of the radiation machines looks like, just to give you an idea. Radiation comes from the linear accelerator, but there's also an imaging device, an X-ray imager that allows us to take X-ray images and, in fact, a CT scan right on the table. And so this allows us to confirm that everything is positioned exactly right before the treatment. And this shows us an example. There's this image in red here is the tumor. And what you see, if you can see that little outline, it's a beam shaping device that is computer optimized to control the radiation intensity. And what you get is, if this is the tumor here outlined in red, this rainbow color scale shows us where the high dose of radiation is. Using that computer control, we can really shape it pretty exquisitely to match the shape of the tumor. And equally importantly, if we look at the more intermediate doses that are spilling out to the surrounding area, we can also shape that. We can actually make it bend around and away from, say, the spinal cord in this case. So that's the degree of control that we have now with the more modern radiation therapy. So once we have a plan that looks good, we go to the actual treatment. And what you see here is that this is the same scan showing the planned target. So this inner red circle is the tumor. We give a safety margin around it to make sure that it's covered. We also look at where other normal structures are surrounding it. And then we can take a scan right on the table. And that's what this shows here. So you can see it doesn't look quite as good as the diagnostic quality CT scan, but it shows us that the tumor is exactly on target and the radiation is going where we want it to go with that degree of precision. So this here just kind of shows you the machine in action. I just need to press the button over here. And so what we have here is the linear accelerator moving around the patient, delivering radiation beams from an arc all the way around the patient. And you can see that the starting and stopping of the beam is synchronized with the patient's breathing. So this is what we call respiratory gated arc therapy. Okay. And that's how we achieve the types of focused dose distributions with that high degree of precision. So does it work? And I think this was an area of a lot of discussion over the past years, mainly because this has been a relatively new treatment. There's been, in the last couple decades now, a lot more clinical data coming out about the results of this type of treatment. And so I can't go over all of that in a few minutes, but just to summarize, now I think it's fairly clear that SABR is superior to the conventional radiation therapy that we've given in the past for early stage lung cancer. And so for those patients who are unable to tolerate surgery, this really now represents the new standard of care for these patients. In addition, what we're lacking in terms of data is, there's no head-to-head comparisons of SABR with surgery. And those types of studies are obviously very difficult to do. But in those patients who have high risk, and just based on the results that we've seen in populations of elderly patients or medically inoperable patients, it looks like that at least for these high-risk patients, SABR, the outcomes are similar to what we've historically seen with surgery. So we think that increasingly for those patients who have a high risk for going through surgery, that this is something that we discuss in our conferences and tumor boards all the time. Which patient is more appropriate for surgery, which one may be too high a risk and should have an alternative like SABR. So ultimately, all of these results need to be confirmed in clinical trials. As I said, this has been kind of an explosive area of growth and information. Many of these trials are things that we're doing right here at Stanford. And then just to give a couple of example cases, this is a tumor here in this panel here that's outlined in red. What you see, these bright dots there are little metallic markers that were implanted to help see the tumor better at the time of treatment. And sometimes that's helpful to do. It's actually not necessary in most cases to implant those markers. But what we see here is that after SABR, this is more than 2 years later, we see the little markers, but we don't see the tumor. So this is an example of a complete response. Similarly, here's a PET scan showing a tumor here in the upper part of the lung. And then 2 months later, you can see that the activity on the PET scan has gone away. The tumor looks smaller. Is it gone or is it not? This is where having experience, understanding how these tumors look on follow-up is very important. You can see a year later, there's stuff out here that wasn't there before. It's this hazy-looking stuff that actually represents an inflammation reaction that's showing up about a year after the SABR treatment. That eventually settles down. We have some scar tissue here, and again, more than 2 years out, there's no signs of the tumor. So another successful treatment, but emphasizing the importance of the follow-up and how to interpret those scans. Okay. So lung cancer, as you're certainly aware, is a growing global epidemic. And early detection now promises to decrease deaths by finding these cancers at earlier stages. And so we need strategies to treat these early stage lung cancers. You've heard about surgical strategies, which are the most standard treatment. You've heard about the advances in surgery that are making it less invasive. But still, there are many patients who are at high risk or who outright cannot have surgery. And we need effective treatments for those patients. And SABR has turned out to be more and more of a standard option for many of them, or at least a good alternative for many patients. And then just as you've heard from Dr. Shrager, it's not just about buying a piece of high-tech equipment. The expertise is actually really important. And numerous clinical trials are ongoing at Stanford and worldwide. So just a little introduction here. Myself and Dr. Dean are the physicians in radiation oncology that use this type of treatment technique. And we're the faces that many patients see, but there's really a big team of people behind the scenes. We have nurses, we have physicists, we have dosimetrists, we have radiation therapists all working together. So it's actually a big team that many of whom the patients never get a chance to meet, but that are all needed to make it happen. So I'd like to thank you for your attention.